This is Tim Horn, and I am the editor-in-chief of AIDSmeds.com, and I am here at the 2008 joint meeting of the Interscience Conference on Antimicrobial Agents and Chemotherapy and the annual meeting of the Infectious Disease Society of America. I have the great pleasure of being here with Dr. Roy Gulick, who is a professor of medicine at Weill Medical College of Cornell University and is also the director of the Cornell Clinical Trials Unit in New York. This is actually a two-part interview, and this is the first of those parts. So Dr. Gulick, I would like to welcome you, and I'm really glad that you could join us.
Thanks, Tim.
You've been quite busy here at the conference. You were the moderator of two symposia really focusing on HIV research, and really more importantly, as to how some of the research that we're seeing now is going to be translating into HIV care, perhaps in the not so distant future. So I think that just based on that, I'd like to talk to you about some of your impressions of here in the conference and kind of tying all of that into the big picture of things. Let's start with, I think, what seems to be the big news coming out of the conference in terms of HIV news here, which is Marie Kitahata from the University of Washington presented some very intriguing data here from a very large cohort study that basically suggested that starting therapy earlier than is currently recommended, which is, right now the treatment guidelines recommend starting therapy once your CD4 counts fall below 350. And that her team is now suggesting that starting earlier seems to be associated with an even greater survival than what the current recommendations say. So I'm wondering if you could start with that and just tell us some of your thoughts on that.
Sure. The first thing to say is that we don't really know what the optimal time to start treatment is. We've had antiretrovirals for 20 years, and it's ironic that we're still asking that question. What's the best time for a patient to start? So as you point out, recent guidelines have looked at cohort data. Now what that cohorts are patients that are followed in clinics and hospitals. That's in distinction to clinical trials where patients are randomized and given treatments and studied. This cohorts is simply describing what happens to people who are in care. So we have a lot of information now about, well, what happens to people in care if they start at different T-cell counts. How do they do? And there's lots of cohorts from all over the world, and sort of all that data has sort of been put together recently, and all the guidelines changed the idea of when to start in the last couple of years. And now all the guidelines seem to agree that people should start as the CD4 drops below 350. So the cutoff used to be 200, and now the consensus is that it's 350.
And what brought us back to 350 in the first place? Before we continue on, how did we go from 200 to 350?
So there's been sort of a balance with HIV meds. In the mid-90s, with all the excitement of the new therapies, people said we should be starting as early as possible. But then the realities of the medications came. And so we realized these can be complicated, they have side effects, drug resistance can occur. And so we were trying to balance those two things, the good effects, trying to reduce illness, and the bad effects, that is toxicities and inconvenience. So in the mid-90s, the cutoff was actually 500. With the realities of the medications, that sort of was changed to 200 over time, realizing that the bad parts seem to outweigh the good parts, and that people should, we said not only just a few years ago, only take the meds when you need them. What's happened recently is that people have appreciated that the meds have gotten more convenient, less toxic. Drug resistance is still an issue, but we have many more drugs than we did even just a few years ago. So the regimens have improved immensely. At the same time, what we're now focusing on is not just the complications related to HIV, but it turns out, surprisingly, that other complications can also be decreased simply by taking HIV therapy.
Other complications meaning?
So things like liver disease, heart disease, kidney disease, cancers that aren't related to HIV, and neurologics, central nervous system disease, can all be reduced as well by antiretrovirals. So the whole field is sort of kind of feeling this out, well, perhaps we should be starting even earlier.
Okay.
So the presentation that we heard is from a big cohort, and it's called the NA Accord. The NA stands for North America, so these were Canadian patients and US patients, and more than 8,000 were studied. And basically, again, what they did was simply to describe the patients. So they came onto the study, and about a third of them started immediately with CD4 T-cell counts above 500, and the other group waited.
How many patients?
It was roughly 1,500 and 3,000 or so. Well, a third and two-thirds of 8,000. And so what they did was simply describe what happened. So people who started above 500 or people who waited for 350 and below. And what they found, surprisingly again, was that there were more clinical events in the group that waited until 350 compared with the group that started at 500. What was the difference? It was something like 70% more clinical events in the people that waited. And then when you looked at those events, well, what actually was happening to people, it turns out most of them were not HIV related. So the conclusion from the study is that we should give serious consideration to starting treatments earlier than we have to date. So I think this is going to cause quite a stir in the field.
Okay. Now, within that study, I think it was intriguing that you really had this head-to-head comparison of those who kind of started immediately versus those who kind of deferred therapy, and that we saw the 70% reduction in the risk of death and clinical events in those who started early. That's all fair and good, but I think what's missing from that are things like, well, if you start early, is there a higher risk of side effects? Is there a higher risk of drug resistance? How does your quality of life? I mean, what about adherence? Like, that didn't seem to be addressed in that particular study. And would you agree that it seemed like that does need to be considered in terms of when to start therapy?
Absolutely. This study is interesting. It doesn't answer the question completely. We still have to consider the pros and cons of starting someone in a particular individual, figuring out what's best of them, weighing everything that's good, everything that's bad. And you're right, some of the factors that you mentioned are still very important for people. But what this study does is to push us. So right now, if you look at the guidelines, above 350, they all say individualize. Some even say defer, that is, don't use them at all. So here's a study that has a suggestion that perhaps starting earlier is actually of benefit. Okay. And I think a lot of us are going to be thinking about that.
So are we looking at a change in the guidelines that saying, really suggesting that we should be starting therapy once the CD4 count hits 500?
So there's one big issue with cohort studies, and that is you're looking simply at what happened. And if you look, people that start early, made that choice, are different than people who choose to wait. And so that's one of the problems with what's known as observational data. It's not like we flipped a coin and said, you start early, you start later. We simply described what people were doing. So this is one study that shows an interesting effect that has some problems because of the opportunity for bias. That is, people who start earlier may have had very good reasons to do it. And so I think time will tell. I think we need more data.
Very, very good. Thank you. This is Tim Horn. I am here with Dr. Roy Gulick from Cornell in New York City, and this concludes our first part of our interview with Dr. Gulick here from the 2008 ICAAC and IDSA.